morning, I'm Dr. RUSHETHA, and today my topic is a comparative study on the superior-temporal and the temporal incisions in small incision cataract surgery for post-operative astigmatism. Cataract is defined as an opacity in the lens capsule or its substance. It is the commonest cause of treatable blindness. Cataract surgery is no more a blind rehabilitation surgery, but it gives absolutely a normal vision. The main aim of the cataract surgery is to provide a good vision quantitatively and qualitatively. Despite the common practice to correct residual refractive error during cataract surgery, there are challenges in predicting the post-operative outcomes and correction required. The main source of variability arises from the surgically induced corneal shape change that results in surgically induced astigmatism. In all types of cataract surgery, the incisions which are made on the cornea or the sclera gives rise to scar, thus altering the curvature of the cornea. These scars usually cause the corneal flattening along the meridian of the incision and steepening in the meridian 90% away. This surgically induced astigmatism is one of the cause of the poor quality of vision post-operatively. Surgically induced astigmatism in turn depends on the type, length and the position of the incision and also on the method of the wound closure. Methods. The aim is to assess the post-op comparative study on the superior-temporal and temporal incision in small incision cataract surgery for post-operative astigmatism. It is a prospective hospital-based clinical study and the duration was from February 2023 to June 2023. The sample size, it included 60 patients with 20 patients in each group. Inclusion criteria. The patients with nuclear and cortical cataracts which ranged from grade 1 to hypermature cataracts were taken. The posterior subcapsular cataract were also selected. Exclusion criteria. The patients with associated glaucoma, traumatic cataract, complicated cataract, lenticular subluxation, poorly dilating pupils, any previous surgeries or any corneal scarring or degenerations, macular degenerations, retinal pathologies and those with intraoperative and postoperative complications were excluded. Data collected from each patient. All the patients should be preoperatively assessed with visual acuity recordings, slit lamp biomicroscopy, tonometry and fundus examination. Astigmatism is measured by using autorefractometer and a keratometer. The IOL power is calculated by contact A biometry by using the SRK2 formula. Preoperative investigations like a complete hemogram, RBS, urine culture and microscopy should be done. The results in my patient, in each group 20 patients were taken with 10 males and 10 females. And in the incision with superior, the surgically induced astigmatism was around 1.57 diopters with plus or minus 0.65. In superior temporal, it was 0.53 diopters. In temporal, it was 0.43 diopters. Discussion. The sutureless manual small incision cataract surgery is a good alternative to phacoemulsification and it gives visual results which are equivalent to phacoemulsification. But the rates of astigmatism are higher due to the larger sizes of the incision. In order to achieve an excellent visual acuity, the effect of astigmatism on the post-operative vision has to be minimized. An increase in astigmatism is observed with an increase in the incision size. A pre-existing astigmatism can be neutralized by changing the site of the incision. If the incision is located superiorly, both the gravity and the blinking of the eyelid tend to create a drag in the incision. These forces are neutralized better with temporally placed incision because in such cases the incision is parallel to the vector of forces. But a superior incision is easy to learn and the upper eyelid covers the incision, so the wound is protected and the foreign body sensation is less. In temporal incision, it is farthest from the visual axis and any flattening which is caused by the wound is less likely to affect the corneal curvature at the visual axis. A temporal incision is advantageous because it can be made easily in deep sockets and small eyes. Also, a superior site is still there for trabeculectomy surgery has to be done for glaucoma in the future. But it is difficult to learn and the upper eyelid does not cover the incision, so the wound foreign body sensation due to the exposure is more and it is exposed to infection. The superior temporal location has the advantage of both the locations and this is free from the effect of gravity and the eyelid pressure and it tends to induce less astigmatism. This study found that the induced astigmatism was lower in the temporal and the superior temporal group as compared to the superior groups. This is the superior temporal incision and the temporal incision. The conclusion of my study is the small incision cataract surgery with superior temporal and temporal approaches provide a better quality of vision due to the significantly less surgically induced astigmatism than the superior approach. But the superior temporal incision has the advantages of both the locations, so it is better than the temporal incision. These are the references.